Ladies and gentlemen, as we're about to begin, please be seated and please fill in the front row first. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to our honorable guests, Dr. Abdul Haris bin Abdul Muhammad, Director of Ashar PZ2, Dr. Nik Faizal bin Zainal, Deputy Hospital Director 1, Dr. Tuku Anasfati bin Tuku Ahmad, Deputy Hospital Director 2, Dr. Nur Jilawati binti Muhammad Ghazali, Deputy Hospital Director 3, all head of departments, specialists, and the rest of HRPZ staff. First and foremost, I would like to thank everyone for allocating time listening to the CME today. I am Dr. Muhammad Shahman bin Shafi'i from the Surgical Department. Will be your MC today. Then, before we start our CME today, I would like to give a few announcements. To sign in for attendance, kindly scan the QR code on the screen that will be displayed before and after the CME session, or can use the attendance link at the live chat in the YouTube channel. For those who join CME via online, any question can ask at the chat box in the YouTube link. Then we are fortunate today to have Dr. Siti Badariah binti Zakaria, our dermatologist. And the topic of the CME today will be the pop of color in between the black and white. Without further ado, I would like to invite Dr. Siti Badariah for CME today.
Assalamualaikum warahmatullahi wabarakatuh. Thank you and welcome to the all the honorable guests and to the audience. I am Dr. Siti Badariah Zakaria, Dermatology Fellow from Dermatology Department, HRPZ2. So today, my topic will be on pop of colors in between black and white. There is a quote saying that there is no beauty without colors, but there is also a quote saying that beauty is in the eye of the beholder. But we dermatology team always know that beauty is only skin that, but the attitude is down to the bone. And us, we Asian people obsessed with white skin. It could be either Asian from Southeast Asian as this website featured, or it could be obsession from the Southern Asian region. For example, Indian and its love for the light skin. The obsession for the white complexion have been portrayed and taken advantage by cosmetic industry, that they feature that the fair companion appears more happier and appears more confident compared to the other darker companion. And it's not only the international advertisement, our local advertisement also portray that whitening properties is the key value that to promote their product. So back in 1960, there is a movement that called Black is Beauty, that to counteract the white obsession from the Asian people. From the dermatologically, we have divided the skin phototype through Fitzpatrick skin pigmentation scale, which is skin type 1. The Fitzpatrick skin pigmentation scale feature skin phototype and tanning ability of each skin type. For the example, type 1 is a patient have a very pale white with freckle with red and blonde color, and the tanning ability, it burns very easily and never thin. And the type 2 patient have pale white skin color with blunt red and light brown, and its the tanning ability, it burns easily and but rarely tans. And our Asian is mostly from the type 4, people from East Asian origins such as Chinese, Japanese, and some Indian and Pakistani. We have medium brown or dark brown skin color with brown, medium brown, and dark brown hair that hardly ever burns but tans very easily. And the other extreme dynamic is the type 6, which is black skin color with black hair color that never burns but tan and very dark. So with our society that obsessed over the skin color, what is have been experienced by this patient. Case 1 is 12 years old girl with no previous illness, with 12-month history of small depigmented patch over left cheek. It's initially started as small depigmented patch over the left cheek, but it's gradually increasing in size for the past 6 months that lead to involvement of bilateral periorbital region, bilateral ear, and even bilateral cheek. And case number 2 is 40 years old female with no previous illness. She has depigmented patch over right periorbital area and the corner of the right lid for the past 10 years with no new depigmented area. For the case 3, she is a 36 years old female with no case of grave disease on tap carbimazole 5 mg/d, which she experienced hypopigmented patch since 1 year ago. It started on both upper limb, then spread to body and face, and it remained static for the past few months. At the first glance, we can see that this patient have homogeneously fair skin, but in this phase, he has depigmented patch over the forehead, bilateral preorbital, and preoral area. And on the back examination, the depigmented patch or large depigmented patch over the back and upper limb, and her body surface involvement is about 30%. And this patient have a condition that called vitiligo. So, what is the burden that experienced by patient with vitiligo? There is a survey in 2015 that state that with topic of living with vitiligo, result from national survey indicate differences between skin phenotype. The study demonstrate that regardless of the skin phenotype, patient with vitiligo experience significant disease-related burden and self-perceived stress. And there is other study in 2021, that is Psychosocial Effect of Vitiligo, a systematic literature review. In the result demonstrate that the most prevalent psychosocial comorbidities were feeling of stigmatization, adjustment disorder, sleep disturbance, and relationship difficulties, including sexual dysfunction. And the factor associated with significant higher burden including female, visible or genital lesion, and patient that is younger, which is age less than 30, and particularly adolescent, and patient that have greater body surface involvement. So to introduce the vitiligo towards all of you, this is outline of my presentation. What is vitiligo? Vitiligo is the most common acquired chronic depigmentation disorder, which result in a loss of functional melanocyte. It affects up to 1% of population worldwide, but have been reported up to 9% prevalence in India. Adult and children are equally affected, and there is no predilection for gender. And almost 50% of people with vitiligo present before the age of 20, and nearly 70 to 80% before the age of 30 years old. So the pathogenesis is multifactorial. It could be due to genetic, autoimmunity, melanocyte destruction hypothesis have been offered, and oxidative stress hypothesis. The pathogenesis of vitiligo initiated because of oxidative stress and genetic factor in 80% of the factor, and environment stressor lead to alteration in membrane lipid, and there is a dysfunction mitochondria lead to production of reactive oxygen species that lead to production of unfolded protein response that secrete exosome that contain mRNA, melanocyte-specific antigen, the AMP, and heat shock protein that present to the dendritic cell, and later on have been recognized by T cell, lead to T cell homing to the skin. UPR, unfolded protein reaction, also have secreted by the stress keratinocyte to secrete chemokine ligand 12 and CCL5 and chemokine ligand 16. Other than this pathogenesis, there is also NK cells and ILC1 that secrete interferon that lead to further stressor to the melanocyte. So for in the case of maintenance of vitiligo, vitiligo is maintained by melanocyte reactive remote memory cell, which remain long life in the skin through interleukin-15 dependent signaling. So normally, skin color is determined by melanocyte. This is the physiology, and the melanocyte is produced by the melanin. The skin color is caused by pigment that called melanin that is produced by melanocyte. So in the fairness of the skin is determined by the amount of melanin in the skin, but not because of the melanin cell count, not because of reduction, but the amount of melanin in the skin. So the clinical feature of vitiligo, there is appearance of acquired milk-white macule with fairly homogeneous depigmentation and well-defined border, and the area is predilection for sun-exposed region, body folds, and periorificial area, although any part of the body can be affected. Various precipitating factors such as physical trauma to the skin, sunburn, physical stress, inflammation, pregnancy, contraception, and vitamin C will precipitate vitiligo, and vitiligo may appear at the sign of skin trauma we call Kaufman phenomena. There is also leukotrichia, or depigmentation of hair within vitiligo macule, that can occur in 10 to 60% and indicate destruction of melanocyte reservoir within the hair follicle. This is the classification of vitiligo. It could be generalized or localized. Appear in the acrofacial area or universal if it involves more than 80% of body surface area, or localized or segmental. So other classification we can use segmental or non-segmental, which is non-segmental involved in about 90% of the patient. This is a picture portray vitiligo universalis. This is segmental vitiligo of the face and neck. This is acro and facial vitiligo and vitiligo with cornerization under breast. This is leukotrichia. So some clinical variant of vitiligo. This is trichrome vitiligo, characterized by presence of patches of intermediate hue, which is hypopigmentation other than depigmentation or normal skin. There is also hypopigmentation. And we have also quadrirome vitiligo, characterized by the presence of fourth color, dark brown, at the site of peripheral repigmentation. It is more often encountered in patients with darker skin phototype. There is also case report pentachrome vitiligo, that occurrence of 5 shades of color, which is white, tan, medium brown, dark brown, and even black. There is also confetti vitiligo or vitiligo ponchu, which show tiny fantate-like depigmentation on the hyperpigmented macule or on normal skin. This is red vitiligo, when the depigmented lesion have a raised erythematous border. And this is blue vitiligo, a blue-gray appearance of the skin, which correspond histologically with the absence of epidermal melanocyte and presence of numerous dermal melanophage. There is comorbid that associated with vitiligo, such as, for example, in our third patient, this patient have vitiligo that associated with autoimmune thyroid disease, Graves' disease. Patient may also have Hashimoto-thyroiditis or alopecia areata. There is potential association with other autoimmune disease such as diabetes mellitus, lupus erythematosus, or rheumatoid arthritis. And as I have explained before, there is increased rate of psychosocial impairment in a patient with vitiligo. So clinical cause of vitiligo is unpredictable, and the flare-up are common and may be separated by stable period. Segmental vitiligo is less common and may affect one or more rarely multiple segment. It's usually earlier onset than non-segmental vitiligo, and the majority of cases, the disease becomes stable within 1 year and recurrence is less common. And for the diagnosis, based on clinical feature, usually biopsy is not required, but may be useful for differential diagnosis in individual cases. And photographic documentation is important for objective measurement for the extension of current depigmentation to assess disease severity and respond to therapy. And Wood's length also beneficial for better presentation of vitiligo patch in fair skin type. This is typical distribution of vitiligo on the hand that we can see in the naked eyes, and under Wood's length that we see more depigmentation patch that appear under the Wood length. So the clinical marker of active vitiligo, based on meta-analysis, patient have Kopner phenomenon or confetti-like lesion as subtype of vitiligo, hypochromic or trichrome lesion, and inflammatory vitiligo such as explained before, red vitiligo and leukotrichia. This is a clinical marker of active vitiligo. What is differential diagnosis of vitiligo? So there is lengthy differential diagnosis that could be secondary to an inherited hypomelanocyte or infectious disorder or post-inflammatory hypopigmentation, paramalignant hypomelanosis, idiopathic disorder, or toxin-induced depigmentation. This is one of the differential diagnosis. It could be nevus depigmentosus that appears as hypopigmented according to dermatoma lesion at the left forehead. This is Piebaldism is a congenital depigmentous patch with white hair present on the scalp and forehead, and patient also have depigmented patch on the trunk and extremities. Patient also have multiple family members that have similar lesion. It is idiopathic causes of depigmentation, which is idiopathic guttate hypomelanosis. There appears as multiple small hypopigmented macule on the background of sun-induced skin damage present on the arm. Another differential diagnosis would be tinea versicolor that appears as multiple hypopigmented macule on the neck, shoulder, and chest. And in this case, this is progressive macular hypomelanosis of the back. Chemical leukoderma, there is white macule mimicking vitiligo on the hand with on patient with chemical leukoderma, and hypopigmented mycosis fungoides in the leg of this patient. And biopsy show there is cutaneous T-cell lymphoma. So how do we manage vitiligo? So first, we need to evaluate patient based on the history, age, onset of the lesion, family history of vitiligo or other autoimmune disease, rate of progression or spread of the lesion, any present concomitant disease, current medication and supplement, occupation that can suggest exposure to chemical, and effect of diseases on the quality of life. Full body skin examination to determine the type of vitiligo, either is segmental or not segmental, extent of the disease with particular attention to the site of vitiligo predilection, such as lips and perioral area, periocular area, dorsal surface of hand, finger, flexure surface of wrist, elbow, axilla, nipple, umbilicus, sacrum, inguinal, anogenital region, and knees, any mucosal involvement, any communal phenomenon, any poliosis or leukotrichia, any trichrome or confetti pattern. And we can assess body surface area that patient have. So for general consideration, treatment modality based on disease severity, disease activity, either is stable, with, which is no increment in size of existing lesion, or absence of new lesion in the previous 3 to 6 months, versus if patient have progressive disease. Patient preference such as cost and accessibility and response evaluation. So, as I mentioned before, we need to assess disease activity. We can divide disease activity to stable, progressive, rapidly progressive, or regressive. There is loose definition of stability in vitiligo, but usually we take 6 months as 6 months, no new lesion within 6 months as stable vitiligo. And for rapidly progressive, abrupt deterioration of developing new lesion and increase in size of old lesion. So for the therapy for stabilization and repigmentation of vitiligo, for stabilization, we can use oral corticosteroid, narrowband UVB phototherapy, minocycline, methotrexate, and vitamin supplementation. And for repigmentation, topical corticosteroid, calcinuric inhibitor, vitamin D analog, narrowband UVB phototherapy, psorialine photochemotherapy, targeted phototherapy, and some experimental agent that available, not yet available. So combination therapy such as phototherapy plus topical or oral corticosteroid, calcinuric inhibitor, or less commonly vitamin D analog, appear to be more effective than single therapy. And we must keep in mind that vitiligo has a highly unpredictable course, and long-term persistence of repigmentation cannot be predicted. and keep in mind that camouflage with makeup can be beneficial. So for the management, we can divide into stabilization of rapidly progressing disease or stable disease. So stabilization of rapidly progressive disease, as I mentioned previously, and for first line, we can use low dose corticosteroid, either oral prednisolone in children given at the dose of 5 to 10 mg OD, or in the adult patient, oral prednisolone 10 to 20 mg OD for maximum of 2 weeks. Other alternative option that have been used could be oral mini pulse therapy with dexamethasone 2.5 mg on 2 consecutive day weekly for average of 3 months, or intramuscular triamcinolone. And stabilization therapy can be given alone or in combination with phototherapy, and disease is expected to stabilize in 1 to 3 months. But keep in mind that oral corticosteroid alone is not effective as a repigmentation therapy for progressing vitiligo. So phototherapy is needed as combination to oral corticosteroid. We offering phototherapy here in dermatology HRPZ. We have narrowband UVB. For patient with vitiligo, it is administered 2 to 3 times weekly, and it requires 6 months to 1 year of treatment to achieve optimal outcome for stabilization and repigmentation. So we must to explain to patient that 1 or 2 UVB, narrowband UVB session is not sufficient for optimization for optimal outcome for vitiligo patient. For non-segmental with mild disease, which is less than 10% BSA, and if patient having localized disease that is limited to face, neck, trunk, or extremities, we can offer topical corticosteroid or topical calcineurin inhibitor. Topical corticosteroid, which is mid to high potency OD or BD, such as mometasone, and other option, super potent topical corticosteroid, as clobetasol. There is no optimal duration, but can be used for 2 months and interrupted for 1 month, then resume for another 2 to 3 months. There is multiple regime for using topical corticosteroid, either 2 months, then interruption for 1 month, or discontinuous therapy such as OD for 15 months, 15 days per month for 6 months, either or. And the adverse effect will be skin atrophy, telangiectasia, hypertrichosis, and acneiform eruption over the site. For the topical calcineurin inhibitor, we have tacrolimus 0.03% for children, or 0.1% for adult, or pimecrolimus 1%. For face or high risk atrophy areas such as intertrigus or genital, it can be applied BD and can be used as combination with a topical corticosteroid. For patients with mild stable disease that is disseminated, which is affecting multiple anatomic sites, we can offer narrowband UVB 2 to 3 times weekly. Or in the case of recalcitrant disease, which is not responding to topical therapy, we can offer targeted phototherapy with excimer laser, narrowband UVB phototherapy, or oral PUVA photochemotherapy. And other option would be transplantation procedure, which is transfer of reservoir of healthy melanocyte to vitiligo skin for proliferation and migration into areas of depigmentation. There is multiple technique for transplantation procedure, One of it is autologous suction blister graft. For patient with non-segmental vitiligo, which is have moderate disease, 10 to 40% BSA, first line therapy will be whole body narrowband UVB that use UV lamps with peak emission of 311 nanometer and induce local immunosuppression and apoptosis that stimulate production of melanocyte, stimulating hormone, basic fibroblasts, growth factor, and endothelin I, and increase melanocyte proliferation and melanogenesis. And as I said before, 2 or 3 times per week for average 9 to 12 months is required for repigmentation. So we are aiming for each phototherapy session, we are aiming there is for mild and asymptomatic erythema which lasted less than 24 hours. So if there is no, if it's not achieved, we can increase the dose of phototherapy accordingly. And usually repigmentation usually begin to appear after 15 to 20 narrowband UVB treatment. If responded well, can maintain beyond 9 to 12 months and up to 24 months or 200 sessions and then taper off. And topical corticosteroid or topical calcineurin inhibitor can be used intermittently. And other option available also, patient could go for home phototherapy. For second line therapy, if patient not responded to narrowband UVB, could be soralin plus UVA photochemotherapy, but it has been replaced by narrowband UVB because if have more adverse effects such as phototoxicity, GI discomfort, and patient required to use ocular protection for up to 24 hours. So this is example of repigmentation of vitiligo with narrowband ultraviolet B phototherapy. There is after picture A and B pre-procedure and C and D after 68 treatment of narrowband UVB. There is repigmentation over the appear over the large depigmented patch over the neck and back. So patient with severe disease, which is non-segmental, stable vitiligo, severe disease more than 40%. So we can offer phototherapy. It could be narrowband UVB or soralin UVA, or we can offer depigmentation. If patient not responding to repigmentation, we can offer depigmentation. Or if patient do not desire repigmentation therapy, what we can offer is monobenzene. We can lead to permanent destruction of melanocyte and induce depigmentation locally and remotely from the site of application. Usually, we treat the exposed area first, and depigmentation of distant site will occur after 3 to 6 months, and it will require 1 to 3 years to achieve optimal result. The adverse effect would be irritant contact dermatitis, pruritus, severe xerosis, alopecia, or premature hair drying. The agent could be either 4-methoxyphenol 20% and 88 phenol solution. For segmental vitiligo, first line therapy, topical corticosteroid and topical calcineurin inhibitor and narrowband UVB, and second line autologous grafting. So how do we assess response to the therapy? Usually response should be re-evaluated in 3 to 6 months of starting treatment, and initial response to treatment in the most cases indicated by appearance of perifollicular area of repigmentation in the vitiligo patch, usually 8 to 12 weeks after initiation of therapy, and after in the topical therapy of 15 to 20 narrowband UVB session. And this is example of vitiligo repigmentation when there is pop of repigmentation area over the central part of the depigmented patch. For the maintenance therapy, patients who responded well and achieved optimal repigmentation, therapy can be gradually tapered and discontinued. But bear in mind, some may require maintenance therapy, either topical therapy twice weekly or phototherapy once every other week. And patients who relapse should go for another cycle of active treatment for repigmentation. And adjunctive therapy that promising topical vitamin D or dietary supplement in combination with phototherapy, alpha lipoic acid, ginkgo biloba, polypodium dichotomous, or microneedling, and technique that use a device that create microchannel in the dermis that has been used alone or in combination with topical agent. There is also investigational therapy that available. Afamelanotide, potent or long-acting synthetic analog of naturally occurring alpha melanocyte stimulating hormone, or prostaglandin E2 that control proliferation of melanocyte by the means of stimulant and immunomodulatory effect. Prostaglandin F2 analog, bimapros or lenapros, or Janus kinase inhibitor, tofacitinib or ruxolitinib. And there is meta-analysis of 5 retrospective cohort studies, including nearly 230,000 patients with vitiligo. It did not find an increased risk of non-melanoma skin cancer or melanoma in the area affected by vitiligo or in non-affected skin in patients treated with phototherapy compared with patients not treated with phototherapy. So that is all from my topic today.
Thank you, Dr. Siti Baria, for wonderful presentation. So there is any question from the floor? Okay, we have one question from Dr. Ahmad Razin. The question is, out of curiosity, did the late of Michael Jackson had vitiligo?
Officially, there is no disclosure. Is that official that say that Michael Jackson having vitiligo and is he had undergone depigmentation therapy. Only God knows what have happened back then.
Okay, any other question? Okay, if there is no any more question, now I would like to invite for the certificate of appreciation to the presenter. Okay, that's all from us. Thank you for attending for CME today. Assalamualaikum warahmatullahi wabarakatuh.